it's my pleasure to introduce Hope Mannion. Hope is the Chief Health and Welfare Actuary with Fidelity Benefits Consulting. She has close to 20 years of experience in the employee benefits field. Hope currently provides health and welfare through leadership and consulting to organizations. Please help me welcome Hope Mannion. Excuse me.
Hi, everybody. You can hear me okay? Sounds like it. And I'm guessing this advances things, and someone will help me if it doesn't. Okay. Let's test. Nope. There we go. There's me. That picture's 10 years old. I have my long hair after I had my first daughter still, and it's been this short for a while, so probably a little false advertising there. But as my introducer said, can you hear okay? Yep, we're good. Oh, what's that? Nope, I'm good. I just wanted to make sure I knew how to use it. Yeah, I have been in the benefits industry for about 20 years. I am an actuary. Do a lot of people know what an actuary is? Yeah, nobody does, right? So we study statistics with an emphasis on financial risk management, and as a result, we're often employed by insurance companies to set your premium rates and set reserves to make sure that the company has enough money to pay all the claims that come in. That's a big application of actuarial work. Another one is managing your pension plans to make sure your employer has put enough away to pay for your pension benefits down the road. I happen to work in health insurance, so I'm an expert in health insurance. And actuaries have a reputation of kind of being nerdy and a little bit introverted. So, you know, any like kind of accountant joke that you hear usually applies to us. I happen to be an extroverted actuary. So, you know, here's a pretty classic joke, which is, what's the difference between an introverted actuary and an extroverted actuary? And the answer is the extroverted actuary looks at your shoes when she's talking to you. So, but I do actually like to get out and meet people and interact. So that's why I went into consulting rather than working for an insurance company. And I'm based in Philadelphia. Go Birds. If anyone saw the game last night, I was very excited. I understand I'm in Bengals Titans territory, but I just got to give a shout out to the home team there. And I joined Fidelity about a year ago as the Chief Health and Welfare Actuary for Benefits Consulting. And as part of that role, I help our organization dig into research and awareness around what our clients and their participants and what our retail customers are going to need as far as paying for healthcare and retirement. Unfortunately, it's not a particularly happy picture. So we're going to talk about some kind of grim and scary stuff a little bit. And a theme I'm going to weave through my comments is recognize how valuable the benefits that you're receiving from the university are in retirement really are, because most Americans do not have any access to employer subsidized or even just access only employer coverage in retirement beyond Medicare. And if you are someone of that description, we're estimating that your out-of-pocket healthcare costs in retirement can be $280,000. So this is an estimate that we do every year. What it is, $280,000 is for a couple, so two people, so you can kind of have that if you're a single person, retiring in 2018 and you are 65 and you are eligible for Medicare. You do not have any employer-sponsored care, any employer-subsidized care. That's kind of eye-popping, right? Like, how is that possible? I kind of thought Medicare paid for everything. Well, it really doesn't. So about 40% of that $280,000 is going to go to Medicare Part D and B premiums. You will get more information around what your specific benefit plans provides that actually puts you in a better position than most Americans are in. But even when you have Medicare Part B and D and A, you are still paying co-payments and deductibles around that standard plan design. So that's about another 40% of that $280,000. And then you also are paying for a lot of prescriptions out of pocket as well. So that we publish this number not to scare people, which frankly it does, but as you're thinking about your total retirement planning, it's important to kind of earmark what you think you might need to be spending on healthcare. And then it's also really important for you all in particular to be working with your UK benefits team to understand what benefits you have, that will therefore reduce this burden on you. Okay, and my understanding is that there are different cohorts of benefits, right? So you need to understand your hire and retirement date to understand what you're eligible for, and that's going to help you figure out what this means for you. Okay, so one thing that's kind of disappointing is most Americans really have no idea what healthcare costs, frankly, while they're working, because your employer is picking up typically 80% of your costs. And most people don't even realize that. So if you're employed, you're kind of shielded from a lot of the cost. But then we really find that people are pretty woefully unprepared for retirement. And in our research, we found that about half of the people expect to spend less than $100,000 out of their retirement savings. So not only are we worried nationally that people aren't really saving enough, then like they just don't even realize how much of what they are saving they're actually going to have to spend on the healthcare, because they're assuming Medicare picks up pretty much everything, and it really kind of doesn't. And only about 40% of workers today are confident that Medicare is even going to be there in the future. I mean, I count myself among that. I don't know what to think, but you know, I've got 20-something years left to work. I don't even know what the U.S. healthcare system is going to look like in the future, and so I'm kind of just trying to save as much as I can, and I would encourage you all with younger people working in your family just to do the same. And then another thing that's a challenge is, as I mentioned, most people do not have retiree medical benefits. So only about 25% of workers in the U.S. have any kind of benefit in retirement at this point. Most corporations and in the private sector have shut down their plans a number of years ago because they just got too expensive, and there wasn't the same protections for pension plans to keep them going. Okay, so try to give you a little context of our 280,000. We started calculating this number in 2002. It was 160,000 then. So 16 years later, it's gone up about 70%. And, anyone surprised to hear healthcare costs going up in the U.S.? No. I mean, unless you're living under a rock, this is a national crisis. And I'll get into some more statistics about how broad and severe the crisis is. But, so a question I get is like, well, where's this going to end? Is there any end in sight? And the answer is not really. You can see there's some dips, right, kind of between 2010 and 2014. And what's that about? Well, the first one was the introduction of Medicare Part D prescription drug benefits. So once that, President Bush passed that, we offloaded some prescription drug costs from the backs of retirees and employers onto the Medicare payment system. And then another dip was when Congress, created some support for Medicare Advantage and other programs under the Medicare system. So really the only time this ever changes is when the government takes another step towards nationalization of healthcare, sadly. Which makes sense, right? They're really the largest payer in our system, and they have the most market weight. And so the only time you're really going to move the needle on increasing healthcare costs that we as consumers and plan sponsors and employers are bearing is when the government picks up more. Okay. All right. I guess there's some animations here that I could have clicked through. So everything I've said so far is really pertained to Medicare population. Well, what if you wanted to retire prior to Medicare, if you're fortunate enough to do so? So Fidelity did some research into people who retired prior to the age of 65 just to see, kind of how did medical costs enter into those decisions, and, were they really prepared for what they saw. And it's kind of interesting that most Americans want to work till 65, but many are not able to, which I found surprising. So as people have been challenged in saving in their 401ks, pension plans have gone away, we're talking about raising the Social Security limit. Part of the solution to that problem of saving for retirement is like, well, I'll just work longer and save more that way, which is a great plan unless you find yourself out of a job and you're not able to find a new one at your previous level of employment, or even more perniciously, you have a health issue, or your spouse does, or someone close to you in your family does, that prevents you from continuing to work. And that is happening more often, and that I find that pretty concerning. So most people want to work till 65 now because of those reasons, but the average retirement age is actually age 62. And for those who retired prior to 65, more than half of them, that wasn't what they wanted to do. So they're probably finding themselves feeling crunched and stressed and pinched for savings and financial security. And and again, really concerning to me, is 30% of them retired early due to a health event, which is just a kind of a nefarious feature of our employment-based healthcare system, that as long as you're healthy enough to work, you have health coverage. When you're not healthy enough to work, you lose that coverage right when you need it. So it's just, things to think about, how to hedge your bets as you're entering into the retirement decision, as well as talking to your friends and neighbors and loved ones about thinking about how to protect themselves as well. Another statistic, which I also found surprising just because I have spent a lot of time thinking about retiree medical coverage, particularly the burden that it is prior to Medicare kicking in, is that 36% of early retirees are paying $500 or more per month in healthcare premiums. I actually think that's low. The $500 is low. This must reflect many people who have employer-subsidized retirement health benefits. Earlier this year, I heard from National Association of Health Insurance Underwriters that there are some markets where in the individual market, right, so like in the exchanges, you can get a policy of age, 55 to 64. You can be spending $1,600 a month just for your health insurance. So what does that mean for you? You have many, if not all of you or most of you, and you'll learn more about this in the next session, you have access to the university programs. Know them, value them, participate in them. They're really, really valuable. And then to be talking to your friends and relatives around looking at what's available in your region sooner rather than later, well before retirement, so that you can know what to expect if you do have to retire prior to Medicare, what you could be paying on the exchanges for your individual coverage if you lose that employer coverage. Another bit of advice is, you can get COBRA, right? So 18 months of continuation on your active plan, but recognize if you've not ever taken advantage of that, your COBRA rate is typically a lot higher than what you're used to seeing in your payroll deductions. So again, if you're planning to retire at 63 and a half and then using COBRA to bridge to Medicare, just think about, talk to HR and find out how big those COBRA rates are and then build that into your plan. Okay. All right, so we're facing a national healthcare crisis. 2016 national health expenditure was $3.3 trillion. And in 2012, the CDC did a study on the impact of healthcare costs and health insurance spending on the American household. And 1 in 4 households reported that they consider healthcare spending to be a burden, and 1 in 6 reported difficulty paying for their medical bills. And at that time, about 8%, so 8 cents out of every dollar was being spent on healthcare. I'm going to guess 6 years later, those have actually all risen quite a bit. I think we're probably up to 10% of every household being spent on healthcare. And that's just, it's a drag on the economy, and it's a drag on households, unless, of course, you're in the healthcare industry, in which case it's revenue, I guess, too. And we do a lot of total well-being research at Fidelity. So, obviously physical wellness is important. Fidelity, we do a lot of work with financial wellness and making sure you have the right insurances and making sure you're saving enough and you have an emergency bank account and that kind of thing. We've started to do more of a dive into how does wellness in one area or another impact stress and wellness in other parts of your life. And the biggest stressor for American households is debt. And it depends on kind of debt, because if you just went and bought a new boat, you might be a little stressed about that, but you're also kind of happy you have a boat, right? But if you are worried about medical debt, there's just this whole other drag of psychological problems that go along with that. Worrying about, am I going to be able to work? Am I going to be able to keep my job? How am I going to pay this debt off if I can't keep my job? What if I lose my health insurance? These kinds of problems. So this is a, it's Friday afternoon. I'm like bumming everyone out. I'm sorry about that, but I'm passionate about it, right? It's a problem we need to start to talk about more head on in our nation. And frankly, the sustainability of the American workforce is at stake. And I have a Warren Buffett quote that I trot out for this slide. Often around the time that we were passing the tax reform and very nice corporate tax cuts, he said, I thought it was interesting, the problem corporations are facing is not taxes, it's healthcare, because we're all running healthcare companies within our organizations. And I work with a lot of corporates, so it's very near and dear to their hearts. And And he said that healthcare is the tapeworm on American global competitiveness in the business world. I thought that was pretty impressive. So, you know, it's getting to be a drag, and it's not going to end anytime soon. So we've got prescription drug trends. Depending on what you're on, those prices are going to continue to go up. You know, 2% if you're on some generics, things like that. 20%, some of these specialty drugs. The good news is they're saving people's lives. They're life-changing, really improving health outcomes. The bad news is they cost a lot of money, and someone's got to pay for it. And it can create very tough choices when you're talking about your health care or the health care of a loved one, and then what else, you know, could you be spending that money on? So that's going to continue in the near future. The consumer price index in general is only about 3%. You can see anticipated medical trend for 2019 is about twice that at 6%, which is better than it's been, you know, a decade ago, but it's still twice CPI. And again, you know, we're all trying to pay for more drugs. And meanwhile, you know, wages are flat. So that pressure that households are feeling around trying to pay for health care and it eating up a bigger and bigger part of your budget every month, you know, these problems just aren't going away anytime soon. And I wish I kind of had something, you know, bright and sunny to say that it's, you know, there's a big fix coming, but, you know, it's just, we're not quite there yet as a society. Again, I think part of the answer is let's be talking about it. Let's be talking to our elected officials, local governments, and start finding a way to support each other's health as a society. So there are a couple legislative things and coming down the pike that I thought you might be interested to know. So Congress and, you know, in Washington, there's not a lot of appetite to like blow up the healthcare system and do something really different, which could potentially bend the trend or not, depending on your political perspective. But they are trying to help in a couple different ways. So we've got a new Patient Right to Know Drug Prices Act that's been proposed. And what this would do is currently in some states, pharmacists are not allowed to counsel you that you may want to ask what the actual cash price of the drug is rather than the copay. So, for example, if your drug costs $2 and your copay is $10, they're going to collect the $10. They're not allowed to say, hey, you know what? If you just handed me $2 bills out of your wallet, you just saved $8. So this law would make that practice, you know, we wouldn't be allowed to bar pharmacists from giving you that kind of financial advice. So that's a good thing for consumers. So talk to your pharmacists. They may not be able to tell you. You can ask them. And then there's a surprise billing proposal also being discussed right now in Washington. And this has to do with like out-of-network charges, right? So you've heard, which may not be quite as applicable for you all because you're in this nice big broad university system here, but do you see the stories in the news where someone had a heart attack, they went to an in-network emergency room, but the anesthesiologist was out of network and they get a $100,000 bill that wasn't covered. So this bill is attempting to kind of alleviate that, those kind of big surprises that really scare people, can often put people into bankruptcy, frankly. Of course, you know, the problem is someone's going to pay for it. So who's going to be paying for it? It's going to go back up into the insurance system and then end up in all of our insured rates. But I think it's better to spread it around in a predictable way rather than people getting six-figure bills when they thought they did the right thing and went to the right doctor. And then, so the Affordable Care Act continues to be debated as hotly as many of us know. There's two updates here. One is on the Cadillac tax, which I refer to as the Hyundai tax, because when they originally thought this up, they thought, oh, well, how about we just put an excise tax on real rich executive health insurance programs? And so anyone who has really rich health insurance benefit, they're going to have to pay, you know, some tax on that. And, you know, what the fabulously intelligent people in our federal government didn't realize is that when they set the thresholds for that value of coverage, it pretty much applies to all of us, right? So it's, you know, it's the Hyundai tax. And now that that's been realized, they just keep kicking it down the road, which is why it hasn't happened yet. And I don't anticipate that tax will ever actually happen. But they can't actually just strike it because then they'd have to take the money out of some other part of the budget, and that's too hard. So they just say, okay, well, instead of 2020, we're going to have it apply in 2022. And then next year they'll say 2020, 2023. So that's what's happening. The other update, just to keep you aware of. And, you know, as people who are employed by a university that has a group-sponsored plan, you're not as at risk here, but there is a push to repeal the Affordable Care Act. It's a lawsuit that's been brought by state of Texas against the United States. 19 other states have joined the lawsuit. With the recent appointment to the Supreme Court, it's probably going to be successful, and they probably will repeal the ACA, which means that your pre-existing condition protections likely eliminated. So if you have friends, loved ones who are reliant on protected pre-existing conditions in the exchanges, just keep watching this in the news. I'm pretty concerned about it because I think a lot of people will lose coverage. So just get that on your radar. I'm going to guess a year from now we'll be hearing a little bit more about it. It's kind of working through the federal court system right now. And I hope I'm being alarmist about it, frankly. I think eliminating protections for pre-existing conditions is political suicide. It's going to affect so many people. There's got to be a way we can provide, care for kids who are cancer patients who as adults therefore are not insurable. I mean, that's just, I can't believe that our politicians are that cynical, but I guess I could be wrong. So, okay, moving on. So we've got some changing demographics as far as our aging population in the Americas. So things are changing, as you can guess. We're anticipating by 2060, we're going to have twice as many people over the age of 65. And part of that is, baby boom demographics, and part of that is people are living longer. So, one thing is neutral and one thing's a positive. But we're going to have a different mix as far as our aging population, right? So more non-Hispanic whites in that older group. And to the extent that poverty in our later years is at this point disproportionately affecting African American populations and Hispanic populations and other populations, it's going to just have to change the way our society is supporting the elderly. And the more people are going to be working past 65. In addition to that, more Americans are aging in place, or I should say more municipalities are just like getting a lot older a lot quickly because young people are tending to leave home and go work kind of in more metropolitan areas. And the result of that is you've got kind of small rural areas who are dealing with more elder care issues. And that puts a lot of stress on the local economy and the local government. So something that we need to be kind of facing head on as a society with our local elected officials as well. So, just a couple more comments on how things are changing. We've got some improvements. So we're going to have more elderly in time, but in some ways the picture has improved. We have a more highly educated elder population going into the future, which is good because people who are more sophisticated and better educated are more likely to seek staying involved in their communities. They know how to use the internet. They know how to use computers and stay connected and these kinds of things. So that's a good thing. Life expectancy has improved to the extent that you enjoy living life. That's a good thing. It was about 68 years in 1950. In 1913, it was 79 years. I mean, that's, when you think about the span of human history, that is a remarkable improvement in a very short amount of time. The gender gap in mortality between men and women has improved. It's now only about 5 years, down from about 7 or 8 years a couple decades ago. And that's a good thing because if it means we're less likely to be alone in retirement if our spouses are living as long as we are, and that's good for our social needs and emotional support. And the poverty rate, largely because of Medicare and Social Security, has really plummeted. So it was about 30% of Americans over the age of 65 lived in poverty in 1968, and in 2018, it's only 10%. I still think 10% is too high, but that's an improvement, largely because of those programs. But we do have some challenges, in addition to the ones I've already kind of rattled off. Our aging population is more obese. That creates more chronic care and complex, kind of diabetes events than our health system has been used to dealing with in the past. Also, again, and this is kind of the double-edged sword of longevity, we have more Alzheimer's and dementia than we've had in the past. Typically, people just kind of hadn't lived long enough for those symptoms to start in their 80s, but now that more people are living into their 80s. So all that is putting a lot of strain on our skilled nursing resources, our skilled nursing facilities, and nursing care. Additionally, more more elderly are divorced. So that's kind of an offset to that good news about that mortality gender gap closing, is more people are alone just because, you know, their marriages have ended. And again, if you are living on your own, you're also more likely to need skilled nursing care and that kind of thing because you don't have anyone at home to take care of you. So good things, bad things, it's just changing, and it's just about, you know, let's be informed and be communicating openly about it as a society. So long-term care. The first thing I'll say is, I think we had a booth back there that was maybe had some information about long-term care available to you on a voluntary basis, and you should talk to them if they're still here, if you get a chance today, because it's an important conversation that I encourage everyone to start thinking about. So I'll give you a little overview of what it is and some points to think about, you know, if you want to, how you want to plan for that. So it's a couple different things, right? It's nursing home, but it's also in-home. In fact, most long-term care is in-home care and non-skilled, okay? So the way they define long-term care and the need for it, or, you know, to get a claim on your insurance, or the way Medicare and Medicaid think about it, is activities of daily living. So how many things do we have on this activities of daily living list that you need help with? And these include, you know, hygiene and grooming, cooking for yourself, paying your bills, you know, being ambulatory, being able to get out of bed, housekeeping, this kind of stuff. So there's a couple different lists used for a couple different purposes. But if you're unable to do a few of those things, you know, maybe it's time now that you've qualified, you know, for your unskilled nursing care in your home under your policy or things like that. So if you have a policy, or when you're looking at policies, you want to take a look at how they define those things, because that's a really important feature of that kind of coverage. So there's a couple different sources of payment for long-term care. We have Medicare, but Medicare only pays for skilled nursing, typically in a facility or in a rehab situation. And the benefits are pretty short, 100 days maybe, in some cases 20 days, depending what it is. I believe the UK program provides supplemental skilled nursing care around that. I'm not the ultimate authority. Definitely talk to your UK benefits team, and I think you'll get a little bit more information on that maybe in the next session, but definitely something to explore as you're thinking about the long-term care decisions as you're planning for retirement. Medicaid pays for more, as far as they will cover some unskilled and in-home stuff, but of course the problem is there's income requirements that typically require that you spend all your assets down. So that's a conversation for your personal, you know, estate planning, right? How do I protect assets and maybe take advantage of Medicaid down the road? You know, these kinds of things. There's a couple different strategies I'm not particularly qualified to speak on. So those are kind of the public payers. And then private, you've got your health insurance, which again, your basic health insurance program has some skilled nursing benefits. They're limited. If you need to be in a home for years, that's not going to cover it. So then you also have your private long-term care individual policies, which you have access to on a voluntary basis. So then the question is, well, do I need to pay for that? It's not mandatory. Do I want to get it? And there's a couple ways to think about it, or questions, and I'll post you to kind of get your juices flowing on that one. And the first is like a really useless piece of advice, right? Don't overbuy, but don't underbuy either, right? Like, that's really helpful. But what I mean by that is you don't think about who in your family may be able to take care of you and assist you, and then ratchet down what level of care you might need to that. Don't underbuy, as far as if you start a policy today, it's a lot harder to buy up more coverage. It's a lot easier to buy down coverage in the future if that payment becomes unsustainable in the future. So that's a conversation to have with a carrier or insurer or your personal financial planner that you're working with, as well as your relatives. Are they willing and able, you know, potentially help you out in 20 years if you need it? So buy early, but only buy what you can afford, which is, I guess, another flip on the first thing I said. So the younger you are when you first purchase the policy, the lower the premiums, you know, just like life insurance, because the insurance company has more time to collect your money before they have to start paying out, so they can set that premium lower. But keep in mind, when you are making that payment decision, you know, say if you're in your 40s, you're going to have lower income, potentially approaching retirement or after retirement, and are you going to be able to continue to afford that level of payment. So again, that you kind of want to find that balance there. And then plan for uncovered expenses. So when you are looking at a long-term care policy, take a look at, does it provide linens within a facility? Does it provide activities charges within a facility and that kind of thing? So you may want a more comprehensive thing that kind of covers all the add-ons and fees within a facility, or if you don't want that, then you want to make sure you have a little bit of savings earmarked in your retirement accounts for that kind of expenditure. Okay. I was very excited to see the previous speaker talk about all the wonderful things that this university offers to you to keep you engaged in your university community as well as your local communities. They have a lot of ways to support you as you're aging post-retirement, and just, again, encourage you to take advantage. Learn about them, get engaged with them now, take advantage of them in the future. Okay, so I touched on earlier that a lot of people don't really understand how Medicare works in our country. They know it pays for your health care after you turn 65, but that's kind of about it. And a lot of people are really surprised to learn that it doesn't pay for everything. In fact, there's quite a lot it doesn't pay for. So, and then you hear about Part A, Part B. What does that all mean? All right, well, Part A is your inpatient, your hospitalization, and your home care. And it's automatic for all Americans who turn 65. And you don't have to pay for it, and you don't have to enroll in it, okay? Part B is your, outpatient, going to the doctor, tests, outpatient surgery, rehab, and you have to buy that. There's a premium, and it's about $120-ish right now, and it goes up every year, and if you're very high income, you may have to pay more, but most Americans are paying the base premium. So Part A and Part B together kind of create a major medical plan that covers something like 70% of your healthcare costs. Part C is subsidized private insurance that adds more coverage, supplemental. So wraps around some more of what A and B together don't pay. Part D is your drugs, okay? So, and again, you have to pay for that. There's a premium for that, and there's different, you can buy individual policies and different plan designs out in the market. You want to do your research, and there's actually tools on the internet that you can enter in what drugs you take or think you're going to take in retirement, and it'll tell you what plan by what carrier gives you the best choices on those drugs and the best design and that kind of thing. Premiums are $30-$40 a month, something like that. And then there's supplemental plans like Medicare Advantage, which is a little bit kind of getting insurance wonky here, but a fully insured capitated product that's UHC is the biggest carrier, and it has kind of ancillary programs tucked into it, like silver sneakers, that programs you can do at the Y, and a couple wellness programs. And then how those work is, rather than Part A, Part B, Part D, Part C all filling in together, Medicare just pays money to a large national health carrier, and then it's on them to manage your care through utilization programs and whatnot to make profits off those subsidies from the government. And so, you are also paying a premium into that, but then it kind of replaces the A through D stuff. Now, so there's some X's here. As it stands today, you all get a supplement through the university if you're eligible according to your service and whatnot dates. So you don't, and that covers what's in C and what's in D. So you will get A, you got to sign up for B. C and D are covered by the university program, subject to confirmation by the next speaker and your UK benefits team, because I'm not totally an expert in your programs. But looking at your website a little bit before I got here, you are in a great position if you're qualified for those benefits, because it really does pick up a nice chunk that most Americans don't have access to at this point. Okay. And this is my final topic, which was covered at length by the previous speaker, and I was really happy to see that, because as important as planning for your healthcare expenditures in retirement, planning for your social network and your engagement is like money in the bank. It's so important. It keeps all those other costs down, keeps your mental health costs down, keeps your physical health costs down. I'm dealing with it a little bit in my own life, where my parents are very involved in their church. They fortunately still have each other. They both work 3 volunteer jobs. My mother-in-law is socially isolated. She was not a social person in her working years. She never actually worked outside the home. And they are about the same age, and the difference in their health status is just remarkable. And I say to my parents all the time, thank you. They did such a great job planning financially for their retirement that they're not a burden on me and my brother, but they're also, they did and continue to do a great job planning for their social and emotional needs in retirement. And I'm really thankful because it's a lot less stress and burden on the whole family. So I won't go on and on because I think you got a lot of that content already, but again, and the university, as mentioned, has just a lot of resources to help you stay connected, and I just encourage you to take advantage of those. So that's all I had. Is any questions, or are they gonna play me off? Yeah. In Medicare Part D. Yeah. Okay. So the question was, what's the donut hole thing in Medicare Part D? And what that is like a really kind of one of the stupidest plan designs any of us in health insurance have ever seen. When Part D was originally passed, there's a standard design that you could different individual products that you could buy would fill in the donut hole, but then you're paying more on a premium basis. But what it said was, first you pay all your drug costs under a deductible, maybe $250, something like that, and then you get a 75-25% coinsurance split, by which I mean you would pay 25%, Medicare Part D pays 75% of your drugs up to the point at which you have spent something like $2,500 on drugs for the year. Then you have no coverage and you are paying everything until you hit a catastrophic coverage limit at about $5,000. Just dumb. Okay, why politics? I don't know. They went to the table, they made sausage, the sausage had a donut hole in it. Since the program was rolled out in 2003, they have done a few things with that donut hole. One is they negotiated for pharmaceutical companies to give 50% discounts on brand drugs when you fill them and you're in the donut hole. So you go to the pharmacy, you're already through that coverage limit, the initial coverage limit, and you're paying for everything on your own. If you went to the pharmacy to get a generic, you would pay for the whole generic. But if you went to the pharmacy to get a brand, you got a 50% discount on that brand. And the total cost of the drug counted toward that catastrophic limit. So that cut, at least on your brand drugs, that alleviated some of the burden. ACA, I think, so Obamacare, started to close that donut hole. So over time, that coverage limit went from like 0 to something. So I think I'm not on my Medicare Part D standard design facts at the moment, but I think in a couple of years, the donut hole is actually eliminated and you don't have to worry about it. Again, with your university benefits, this isn't an issue because you're getting drugs through that Medicare supplement. But if you have, folks who are looking for a Part D individual plan on their own in the market, that is something that they need to be asking about, is what's the plan design? How does it compare to the standard plan? Is there a coverage gap? And then what's the premium differential for not having the gap, frankly, because you're going to pay a little more. Yeah. Depends on where you live. And I would, oh, I'm sorry. Are there when you're on Medicare, are there restrictions on where you can get care? Right. Okay, so typically how Medicare works is they are the largest negotiator of healthcare services in the country, and they therefore pay the least, okay, because they've got that market power. And so you do have providers who say, I don't want to contract with Medicare because I don't think they're paying me enough. And this is a constant battle. And then, or the other thing they'll do is they'll take Medicare and then they'll charge what they think is a loss back to the private insurers so that we're all actually paying for that in our private insurance premiums and this kind of thing. So it's all in the system. So in some parts of the country where there's just the least generous Medicare remuneration back to the providers, you can get problems where there's too many providers who aren't accepting Medicare. I don't think that's a problem in this area, and I would kick that one to the local benefits team. And, again, you do have the health system providers here, and as far as I know, they would be taking Medicare. So, yeah, the answer is sometimes. That said, and that's problematic, but that said, there's really no option but to be on Medicare once you're eligible for it. So it's an unfortunate feature at times for people, and it's not convenient, and they may not get to the doctor that they want, but the alternative of just not having coverage at all is just really not feasible for most. Anybody else? Okay. Okay, I do have to catch a flight home. You were the last thing between me and my flight to see my babies. But thank you all for having me. Really appreciate it. It was fun.